My name is Dr. Paula Abola, and in this presentation, I will be discussing how regional disparities in Parkinson's disease treatment across the Baltic States may influence not only physical outcomes, but also mental health and overall quality of life. So when we talk about Parkinson's disease, the conversation is often centered around the motor symptoms. So we think about tremor, rigidity, slowness of movement, and difficulties with walking. So these are, of course, core features of the disease. However, Parkinson's is not only a motor condition. It is a very complex, progressive disorder that affects multiple aspects of a person's life. In fact, many of the most distressing symptoms reported by patients are non-motor symptoms. So these include anxiety, depression, sleep disturbances, cognitive decline, fatigue, and also loss of independence. So over time, these symptoms can become just as disabling or even more disabling than the motor symptoms themselves. And because of this, quality of life in Parkinson's disease is not, but it's also shaped by emotion. And of course, access to support systems. Access to treatment is not equal. And more specifically, how do differences in healthcare systems translate into differences in mental health and quality of life for people living with Parkinson's disease? So to explore this study that I'm presenting today, it compared Parkinson's disease treatment across 3 Baltic countries, Latvia, Lithuania, and Estonia, using Germany as a high resource comparator. So the study used the structured qualitative comparative policy mapping approach. So in simple terms, that means that we analyzed how national healthcare policies, reimbursement systems, and service delivery structures shape what treatments are actually available and accessible to patients. And we focused on 3 key domains of care. So first of all, pharmacological treatment, so medications that are used to manage Parkinson's symptoms. Second, the device-assisted therapies, such as deep brain stimulation and infusion treatments, which are typically used in more advanced stages of the disease. And third, rehabilitation and supportive therapies, so physiotherapy, occupational therapy, speech therapy, palliative care, and home-based support. And now I want to walk you through the findings, but of course, also continuously connect them to what they mean from a patient perspective. So let's start with medications. So across all countries, basic Parkinson's medications, such as levodopa, dopamine agonists, and monoamine oxidase B inhibitors, they are available. However, the way these medications are reimbursed, that differs significantly. So in Germany, these medications are fully reimbursed. So patients generally don't face financial barriers to accessing essential treatment. And physicians also have flexibility in prescribing and adjusting medications without complex approval processes. In Estonia and Lithuania, there's also full reimbursement for standard medications. And this is an important strength of these systems, as it protects patients from direct financial burden in basic treatment. But then we come to Latvia. The situation there is very different. The medications are only partially reimbursed, typically at around 75%. So this means that patients must pay the remaining 25% out of pocket. And purely from an economic perspective, this may seem like a policy detail. But from a patient perspective, this has real consequences. So Parkinson's disease, it's a chronic condition. Treatment is lifelong. Patients often require multiple medications, sometimes at increasing doses as the disease progresses. So over time, even a 25% copayment becomes a significant financial burden. And this can lead to very difficult decisions. Patients may delay refilling their prescriptions, they may reduce their doses, and they may avoid adding new medications that could improve symptom control. And when medication adherence decreases, symptoms become less controlled. So this is where the mental health dimension begins to emerge. So when symptoms worsen, patients may lose confidence in their ability to function. They may withdraw from social activities. They may feel frustrated, anxious, or even hopeless. So the financial stress itself can also contribute to anxiety and emotional strain. So already at the level of medication access, we see how policy translates into lived experience. And now we move to device-assisted therapies. So these therapies, such as deep brain stimulation or infusion treatments, They're typically used when medications alone are no longer sufficient to control symptoms. So they can significantly improve quality of life for patients with advanced Parkinson's disease. So in Germany, these therapies are broadly available and they are reimbursed. There are multiple specialized centers, and patients who meet clinical criteria, they can access these treatments without direct financial barriers. In Estonia and Lithuania, some of these therapies are reimbursed, but access starts to get more limited. So this is often due to capacity constraints, limited number of specialized centers, long waiting times, and administrative requirements. In Latvia, however, device-assisted therapies, they're not reimbursed at all. So this means that in practice, these treatments are inaccessible for most patients. So now imagine being a patient with advanced Parkinson's disease. Your symptoms, they're no longer well controlled by medication. You know that there are treatments available that could potentially improve your condition. But those treatments, they're not accessible in your country. And this creates a very specific type of psychological burden. This is not only about physical suffering. It's also about the perceived inequality. It's about knowing that your outcome might be different simply because of where you live. And this can lead to feelings of frustration, injustice, and also loss of hope. So patients may feel that they have reached the limit of what the system can offer to them, even though additional options, they exist elsewhere. And that perception, it can significantly affect mental health, particularly in chronic and progressive conditions, where maintaining hope, it's an important part of coping. And now I want to move to the third domain, rehabilitation and supportive therapies. So these include physiotherapy, occupational therapy, speech therapy, and palliative care. So these services, they are essential for maintaining function, communication, and of course, independence. So in Germany, these services are relatively well developed. There are multidisciplinary care models, inpatient, outpatient programs, and home-based support services. In Estonia and Lithuania, rehabilitation services are reimbursed, but the access is limited by workforce shortages and regional disparities. And again, we come to Latvia, where access is even more constrained. There are long waiting times, limited numbers of trained specialists, and restricted availability of services. So in some cases, patients may receive only a small number of sessions per year, which is not sufficient for a progressive condition like Parkinson's. And speech therapy, which is critical for communication and swallowing, is very limited. And also palliative and home-based care services, they are underdeveloped. So as a result, much of the care burden falls on the family members. And now again, considering mental health implications of this. So when rehabilitation is limited, patients may lose function faster than necessary. They become less mobile, less independent, and less able to communicate effectively. And that, of course, can lead to social isolation. It can reduce participation in daily life. It can affect identity and self-esteem. And at the same time, when families take on the majority of the caregiving responsibilities without adequate support, caregiver burden increases. And this can create stress within the household, which can also affect the patient's emotional well-being. So again, we see that may appear as a structural or policy issue, but it's actually deeply connected to mental health and the quality of life. So across all three domains, medication, advanced therapies, and rehabilitation, we see a pattern. Germany is providing the broadest access. Estonia and Lithuania, they provide strong access to basic medications, but they face limitations in advanced and supportive care. And Latvia faces the most significant constraints across all domains. So these differences, they align with broader differences in healthcare financing. Germany, it invests a high proportion of its GDP in healthcare, with lower out-of-pocket costs for patients. But in contrast, the Baltic States have lower overall health expenditure and higher out-of-pocket costs. So this means that patients in these countries often bear a greater share of the financial burden. And as I discussed today, financial burden is not only an economic issue, it's also a mental health issue. So to conclude, the key message of my presentation is that disparities in Parkinson's disease treatment are not only about access to medical interventions. They're also about how patients experience their illness. They influence symptom control, independence, emotional well-being, and sense of dignity. So they shape whether patients feel supported or unsupported, whether they feel hopeful or discouraged, whether they can maintain quality of life over time. So improving access to Parkinson's disease treatment, it should not be viewed only as a clinical or economic priority. It should be recognized as a mental health priority. So future research should aim to directly link policy differences with patient-level outcomes, including quality of life, mental health, and of course, caregiving burden. And because ultimately, the goal is not to treat the disease, it is to support the person living with the disease. And again, thank you very much for joining today's presentation.